Hello and welcome to part 3 on etiology of cataracts. Today we are discussing the various syndromes that can cause a bilateral cataract to develop. So now we shall be dividing these syndromes leading to cataracts into those developing along with the musculoskeletal syndrome, disorders with the craniofacial anomalies, specific chromosomal disorders with bilateral cataracts, syndromes with dental issues, syndromes with skin manifestations, and those with renal disorders. Now, dividing the etiology like this makes this information much more organized and help us to recall it when we most need it. Ultimately, we want all of you to be able to join these dots and be a genius and not end up like poor Mr. Bean in your exam. So now let's get started. So here we shall be talking about 4 such syndromes, and the last 2 are actually the examiner's favorite. So here we have the Smith-Lemli-Opitz syndrome, Conradi-Hunnerman syndrome, myotonic dystrophy, Weill-Marchesani syndrome. The first one that we'll discuss is the most important, and that is the myotonic dystrophy. The myotonic dystrophy is a chronic, slowly progressing multi-system disorder that basically affects your muscle, leading to wasting of the muscles, and therefore it is also known as muscle dystrophy. Now here we will see hypotonia, that is decreased tone in the muscles, and it will manifest as a floppy infant. Apart from that, you will see generalized muscle weakness, and you can also see a weakness in the overall facial muscles as well, leading to ptosis, drooping of the mouth, and also other weakness of the facial muscles. Apart from that, you can also notice that there will be a temporal hollowing over here which is present. Now, what is a classic feature of myotonic dystrophy? That is the presence of a myoclonus. A myoclonus is nothing but it is a sustained contraction of the muscle. Once a patient with myotonic dystrophy holds an object, it becomes extremely difficult for them to release it. Also, a reaction that one can elicit is by carrying out percussion on the thenar eminence of the thumb. What happens is that if you actually do percussion on the thenar eminence, the thumb will move sharply into opposition and adduction, as you can see, and it will return to its original position very slowly. So this is a test which can actually elicit the presence of myotonia or myoclonus in case of myotonic dystrophy. Now, however, what is important for us is actually the presence of cataract in these patients with myotonic dystrophy. So here, initially, what you see in these patients is presence of these iridescent dust-like particles, and this gives it a characteristic appearance, and this appearance is known as a Christmas tree cataract. Okay, so often in examinations you're asked what is the classic cataract you see in case of myotonic dystrophy, and the answer to that is a Christmas tree cataract. Right now, this lustrous rainbow-like play of colors that you see is basically caused by differential refraction of the light waves, which is caused by the lens fibers in myotonic dystrophy. However, that Christmas tree cataract appearance is only seen in the early stages. Later on, subsequently, the cataract spreads and it progresses to develop a more cortical location, and it progresses to become a cortical or a posterior subcapsular cataract, and this cataract actually has a star-like appearance or a stellate appearance, and like what you can see in these pictures is actually a posterior subcapsular cataract assuming a morphology of a star, and therefore it's called a stellate cataract as well. Okay, so in myotonic dystrophy we have discussed 2 types of cataracts. We have discussed an early Christmas cataract and a late posterior subcapsular stellate shaped cataract. Now, we discussed the myotonic dystrophy, and now let us discuss the next syndrome, that is the Smith-Lemli-Opitz syndrome. Now, this is not a very important syndrome for us, so we shall just be focusing on some important facial features, The next syndrome that we'll talk about is the Smith-Lemli-Opitz syndrome. Now, the syndrome is not very important for us because we don't have any characteristic cataract which is seen in these kids. However, you can just remember a few facial features. So they will have microcephaly with bitemporal narrowing. So you can see they have a small head and the temporal part is actually compressed. They have bitemporal narrowing of the head. Apart from that, if I have to remember a few points about Smith-Lemli-Opitz syndrome, I would try to remember that they have this short nose which is upturned. So this is called an anti-inverted nares along with a pretty long philtrum. Okay, so they can have ptosis. They will have bilateral ptosis with sometimes presence of an epicanthus as well, retrognathia, polydactyly and syndactyly. So here in this picture, the third picture, you can actually see two toes which are fused together. So when fingers or toes are fused together, that's called syndactyly. So if I have to remember a few points regarding Smith-Lemli-Opitz syndrome, I would remember that they have anteverted nares along a philtrum, bilateral ptosis and presence of syndactyly, and of course bilateral cataract. Now, the third syndrome that we'll talk about is the Conradi-Hunnerman syndrome. So this is also a musculoskeletal disorder. So here you can remember that they basically have a short stature. Along with that, they have patchy alopecia, that is scantiness of hair in certain locations. And they will have this bend in the spine which is called scoliosis. So a lateral bend is called scoliosis. Along with that, they will have asymmetrical limb shortening. Now, one thing which is very important over here, which you can observe, is this presence of a characteristic rash on the trunk and on the extremity, and this is called ichthyosiform erythroderma. Okay, so the scaly, dry rash, which you can see in the form of a spiral in cases of Conradi-Hunnerman syndrome, is called ichthyosiform erythroderma. So if I have to remember something about Conradi-Hunnerman syndrome as an ophthalmologist, I would remember that they basically have musculoskeletal problems with a skin feature which is called ichthyosiform erythroderma. They have asymmetrical limbs along with scoliosis, alopecia, and what is of concern to me is the presence of bilateral cataract. Now, the fourth one, which is also examiner's favorite, is the Weill-Marchesani syndrome. So, Weill-Marchesani syndrome is also referred to as the spherophakia brachymorphia syndrome. It is basically characterized by defects in the fibrillin. Now, the fibrillin is basically involved in the zonules of the lens, and because there's a problem in the fibrillin, here patients will actually have zonular weakness. Apart from that, the shape of the lens is quite abnormal. They have an abnormally hyperspherical lens, and this small abnormal lens can easily dislocate into the anterior chamber because of the weakness of the zonules, and this can actually cause a pupillary block leading to secondary glaucoma. So that is one point that you must remember. Now, because the shape of lens is quite spherical, they will have a refractive error, and that is myopia. Okay, so individuals with Weill-Marchesani syndrome basically have severe myopia because of the shape of the lens and also because of the anterior dislocation of the lens into the anterior chamber. But normally in myopia, we know that in normal patients, we have a deep anterior chamber with some changes in the retina because of the longer axial length. However, in case of Weill-Marchesani syndrome, you will notice that despite having high myopia, the myopia is basically lenticular myopia, and therefore the anterior chamber depth will be normal or smaller, and there will be no myopic retinopathy present in these patients. So that's one important point that you must remember. Apart from that, systemic features, what patients with Weill-Marchesani show is that they have short stature, they have the stocky build to their fingers, they have small stubby fingers, and these small fingers is actually called as the brachydactyly. So what you can see in the first picture is that the presence of this brachydactyly or short fingers. Of course, they have microspherophakia with anterior dislocation of the lens. So this was about the 4 musculoskeletal syndromes, and as I told you, the myotonic dystrophy and Weill-Marchesani syndromes are something that you must remember. Moving on to the syndromes which have specific craniofacial anomalies associated with the cataract. So we must remember here the hallerman-Streif francoid syndrome. Now here we don't have a characteristic cataract associated with this syndrome, and therefore sometimes just remembering the name is also enough for you. Also, if you want to take a step ahead and remember some features, I recommend that you remember that they have this bird-like faces and they have this patchy alopecia. So they have hypertrichosis and they have atrophy of the skin, and they can age also really fast. Okay, so that is something that you must remember. So they have congenital bilateral cataract, small eyeballs, bird-like faces, and hypotrichosis. What about the second condition associated with craniofacial anomalies? As you can see in the picture, is the Rubinstein-Taybi syndrome. But here, two important points that you must remember regarding this Rubinstein-Taybi syndrome, apart from having cranial facial anomaly, is some features related to the fingers and the toes. Okay, so they will have broad first toe and broad thumb, which is present in these patients. Apart from that, they will have this characteristic bend present in the fifth finger, and this characteristic bend that you can see over here is called clinodactyly. So clinodactyly is defined as a congenital curvature of the digit distal to the metacarpal phalangeal joint in the coronal plane. So this finger is not straight, it's slightly bent, and this is called clinodactyly. Apart from that, they will have a much smaller head circumference. So Rubinstein-Taybi syndrome is associated with a broad first toe and a broad thumb along with clinodactyly. Now, often you are asked in exam that what syndrome is associated with bilateral cataract and pigmentary retinopathy. Now, here the answers are two. You can actually answer it as salt and pepper retinopathy, which is seen in case of rubella syndrome, or the examiner might also be asking you about the bardet Moon-Biddle syndrome, right? So in this bardet-Biddle syndrome, basically there are mutations of the proteins which are involved in the function of the cilium, okay, which are specialized cellular organelles which are common in various cell types throughout the body. So they're important in your eyes, they're important in your kidneys, genitalia, brain, and so on and so forth. So when the cilium is defected, bardet-Biddle syndrome results, and here in the retina you will have retinal degeneration. You can have this pigmentary clump, and therefore this is the reason that you actually come across this syndrome even when you read about the retinitis pigmentosa. Okay. Apart from that, usually there is obesity, and more common the truncal obesity is present in bardet-Biddle syndrome, and they have this postaxial polydactyly. So extra fingers or toes, if you see them present on the ulnar side, that means on the side which is opposite to that of your thumb, okay, that is called postaxial polydactyly. So if I was to see an extra finger on the side of the thumb, that is called preaxial polydactyly, whereas if you see extra fingers on the ulnar side, that is called postaxial polydactyly. Okay. Now, apart from that, they have hypogonadism and genitourinary anomalies because the cilium is also required there, and they will have renal abnormalities. So let me tell you that bardet-Biddle syndrome is also a very important examiner's favorite syndrome that you're commonly asked about in the exams. So now let us talk about the disorders which are associated with kidney problems and cataract. So here we have two disorders, one which is associated with an anterior lenticonus and cataract, that is the Alport syndrome, and the other one associated with a posterior lenticonus, and that is called Lowe syndrome. And the common thing between them is that both of them involve your kidneys, right? Now, in my first video on the etiology of cataracts, I already mentioned to you what is meant by the anterior lenticonus. So, anterior lenticonus is actually a bilateral axial projection of the anterior surface of the lens into the anterior chamber. So, here obviously you have a bilateral anterior lenticonus in case of Alport syndrome that you can see here. Right now, this lenticonus appears to give a reflex like this when you observe this lens under retroillumination, and this appearance is typically called an oil droplet sign. Now, I hope you actually know what is meant by an oil droplet cataract as well, and where you see an oil droplet cataract. So if you know the answer, give us the answer in the comment section. Now, almost all of these patients who have Alport syndrome, they have a hereditary condition, and it is also characterized by a presence of progressive sensory neural deafness. Okay, so that is one important point you must remember. So they have renal disease associated with abnormal glomerular basement membrane. Okay, so you have the nephrons in the kidney, that nephrons have a glomerulus, that's a tuft of capillaries. Every capillary will have a basement membrane on which the endothelium will sit, and it is actually the basement membrane which is affected in case of Alport syndrome. Okay, now apart from that, you can also see some features in the retina as well. So you can see presence of these whitish flecks or whitish dots in the posterior pole or in the retina. Basically, sometimes it can be located just near the macula, so they are called the perimacular flecks because they are concentrated near the macular area, and sometimes they can be spread in the peripheral part as well. Okay, apart from that, you will see the presence of posterior polymorphous corneal dystrophy also. Okay, so I have to remember something about Alport syndrome, I will remember that Alport syndrome starts with A, and therefore we see bilateral anterior lenticonus along with associated cataracts. Then I will remember that they have flecks in the retina. They can have posterior polymorphous corneal dystrophy, and they have sensory neural hearing loss. What about the second disorder associated with kidneys is the Lowe syndrome. Okay, so the Lowe syndrome is also referred to as the Oculo-Cerebro-Renal syndrome of Lowe. Now it is called Oculo-Cerebro-Renal because it is associated with problems in the eye. It is associated with the problems in the brain and also in the kidney. Now usually this affects the male children. They will have bilateral congenital cataract associated with lenticonus again, but here the lenticonus is the posterior lenticonus. Okay, apart from that they will also have severe hypotonia. Okay, apart from that, the renal problem what they have in Lowe syndrome is the presence of a Fanconi syndrome. Now Fanconi syndrome is nothing but it is a syndrome of the proximal renal tubules where there's inadequate reabsorption in the proximal renal tubules of the kidney. So what happens is that it results in various small molecules of metabolism like the glucose, amino acids, and uric acid. They actually, instead of being reabsorbed, they are actually excreted and passed off into the urine. Okay, so one important diagnostic test that you can actually carry out to detect Lowe syndrome is the presence of proteins and amino acids in the urine. Okay, that is called proteinuria. So that is the most sensitive marker for renal involvement in case of Lowe syndrome. And you can also retrospectively diagnose a case of bilateral cataract which has proteinuria as Lowe syndrome, and this presence of protein in the urine is basically Fanconi syndrome. So are you with me? Yes, you survived till now. Well done. So here's the torch for you. Bask in the light of your triumph. That's it? No. Let's talk about torch infections. So definitely, how can we not talk about infections as the cause of bilateral cataracts in pediatric population? Okay, so torch basically stands for, T stands for toxoplasma, O is other pathogens like syphilis, R is rubella, C is cytomegalovirus, H is herpes simplex virus. Apart from that, another organism which can cause bilateral cataracts is actually varicella. So here we shall actually be talking about the rubella cataract. Why? It's because it is actually a high yield point. That rubella cataract basically is a pearly nuclear or cataract. That means it basically affects the nuclear area of the lens. Apart from that, sometimes you can also have a more diffuse cataract. Right? So it occurs in almost about 15% of the kids who are affected with rubella in the antenatal period. Apart from that, you can see some pigmentary retinopathy in case of rubella infected kids, and this is called a salt and pepper retinopathy. So all of these are actually high yield points. Make sure that you share them with your friends as well. Don't be a knowledge Scrooge, never hoard your knowledge like the squirrel with acorns. Always share your wisdom, be a sharing superhero. Okay, so moving on, what chromosomal anomalies can lead to cataract in children? Here we are talking about trisomy 21, that is Down syndrome. Trisomy 13, which is Patau syndrome. Trisomy 18, Edwards syndrome, and Cri-du-Chat syndrome. So first we'll talk about the most talked about syndrome, and that is the Down syndrome trisomy 21. So here in trisomy 21, you're going to see a presence of fold near the eye, which is called an epicanthus. You will see an upward slant to the eyes, and along with that, a flat nasal bridge. Now, some important points that you must remember is the presence of a single palmar crease, wide gap between the greater toe at the first and the second toe. Apart from that, you can also see clinodactyly. I already told you what is meant by clinodactyly when I was talking about the Rubinstein-Taybi syndrome, right? So what is important for us is the presence of cataract in a child who has Down syndrome. A characteristic cataract that you see in Down syndrome is referred to as a blue dot cataract, and this blue dot cataract is called cerulean cataract. Right, so obviously the cataract morphology can be varied. However, most commonly talked about is the cerulean cataract, which you can actually see over here. Now, other features that you can see is the presence of these spots on the iris. So these spots on the iris are actually whitish or grayish in color in the periphery. Okay, this is basically because of the aggregation of connective tissue in the peripheral part of the iris. So this is called the brush field spots. Now, an important point to remember is that these brush field spots tend to be actually obscured by pigmentation of the anterior border layer of the iris in patients with darker irides. So, in skin of color or in colored patients, it's better not to try to find these brush field spots. Okay, they are much more likely to be observed in children with lightly pigmented eyes. Of course, they can have keratoconus and they can have glaucoma. The next syndrome that we'll talk about is the trisomy 13, that is the Patau. The next syndrome that we have is trisomy 13, also referred to as the Patau syndrome. So here you will have this cleft lip and palate, and we have this hypothyroidism, that is decreased distance between the two eyes. So it's called hypothyroidism. There will be a broad and a flat nose, low set ears, post-axial polydactyly. Of course, there will be microphthalmia and heart defect. Now, if I have to remember something about Patau syndrome, I would try to remember a cleft lip and a cleft palate with hypothyroidism. So this is one important point that we often get confused, is that, and this is something which is tested also in exams, that Patau syndrome is actually associated with hypothyroidism and not hyperthyroidism. Hypothyroidism is decreased distance between the two eyes. Now, let us talk about the third syndrome, that is the Edwards syndrome or trisomy 18. So trisomy 18 or Edwards syndrome basically has cataract along with the presence of ptosis, and you will have the presence of corneal opacities. So actually speaking, Edwards syndrome has actually the involvement of the entire eyeball as such. So you have small eyeballs, along with that you have clouding of the cornea. So your cornea is involved. You have cataract, that means your lenses are involved, and then even the retina is involved because you have coloboma and vitreoretinal dysplasia. Apart from that, two features which are specifically asked, the presence of a rocker bottom feet. A rocker bottom feet is a feet which has excessive convexity, which is not very clearly shown in this picture, but they'll have increased convexity of the sole or the sole of the feet. Apart from that, they have this prominent heel or calcaneus. Okay, so a presence of a convex sole and a prominent heel is called a rocker bottom feet, seen in case of Edwards syndrome. Apart from that, you will have a clenched fist appearance with the when the feet is actually clenched. What happens is that the second and the fifth finger will actually be overlapping the third and the fourth. So you can see over here, the second finger and the fifth finger is actually overlapping the middle two fingers. So we discussed about trisomy 21, trisomy 13, trisomy 18, and now we'll talk about the last chromosomal disorder, and that is the Cri-du-Chat syndrome. Now the only thing which I want you to remember here is the presence of a downward slant and the presence of something which is called as a cat cry or a call of the cat. So basically Cri-du-Chat is actually a French term referring to the characteristic cat-like cry of the affected children. Okay, and Cri-du-Chat basically means a cat cry because their voice is like that, because of which this is called a Cri-du-Chat syndrome. And the chromosome involved over here is actually chromosome number 5, and there is actually a partial deletion on the chromosome number 5. Now, important feature that I want you to remember is the presence of a downward slant here. Okay, so in case of your Down syndrome, you actually had an upward slant, whereas in case of Cri-du-Chat syndrome, you have a downward slant. And here we have a hyperthyroidism, which is in quite contrast to that of Patau syndrome, which has a hypothyroidism. They will have a small jaw, a rounded face, and important thing is that they have a characteristic cat-like cry to their voice. Now, what about dental anomalies? We have two syndromes here, Nance-Horan syndrome, Lenz microphthalmia syndrome. Don't worry, we are coming to an end. Important, yes, it's important. You should know Nance-Horan syndrome because it has so many characteristics names. It not just has smaller cornea and smaller eyeball, it actually has so many different features when you actually discover their tooth and their teeth, right? So you'll have small teeth in case of males. The canines will have this dome shape with three lobe patterns. So it's called a tri-lobed edges to the canines. The incisors can look like screwdrivers. The molars can actually take the shape of mulberry. And one important type of cataract, because that is what we are studying here in this video, here is the presence of Y-shaped sutural cataract, right? So this opacity in the form of Y occupying that sutural zone, the sutural area of the lens, the Y-shaped suture cataract is associated with this Nance-Horan syndrome. Okay, so I'm so sorry for the spelling mistake. This is actually N-A-N-C-E, Nance-Horan syndrome. Okay, so it's actually an X-linked condition comprising of distinctive dental and facial anomalies together with your congenital cataract and microcornea. Now here basically the females are just the carriers and the males are affected. So as you can see over here, this is a child, this is a guy who's affected with Nance-Horan syndrome. Okay, it's actually suspected that he has this Nance-Horan syndrome. The eyeballs are quite small, the cornea is also small, and his sister, who was quite asymptomatic, when she was taken up for the examination, she was found to have this sutural presence of the sutural lens opacity, and therefore the doctors went back and actually did the genetic testing and found and confirmed that the boy's diagnosis was indeed of the Nance-Horan syndrome, and the sister was actually a female who was just a carrier. Okay, and therefore she had this Y-shaped sutural lens opacity, but none of the other features like microcornea and microphthalmus. Now, what about skin disorders which can lead to cataract? So we have Cockayne syndrome, Rothman-Thompson syndrome, atopic dermatitis, incontinentia pigmenti, progeria, and ichthyosis. So you can actually remember them with this slide. So here I try to look at this cock and remember the Cockayne syndrome. I look at this spin top and remember atopic dermatitis. I look at this child who seems to be aging too fast and remember the progeria. Again, I look at this fish scales and remember the disease which has fishy scales on the skin, which is ichthyosis. Okay, so that way you can actually remember. And of course, I try to remember one more thing, which is IP, that is incontinentia pigmenti. Okay, so here what is important for us is the atopic dermatitis cataract, because it has a characteristic appearance to it, and that appearance is that of a shield-like dense plaque like cataract. Okay, the cataract is quite dense, therefore it's called shield-like cataract, and this shield-like cataract is present in the anterior subcapsular area in the form of a plaque. Okay, and because it's present in the form of a plaque, it actually contracts and wrinkles the anterior capsule as well, right? So where do you see the shield-like cataract? It is seen in case of atopic dermatitis. So that is one important point. Okay, so we are done with the atopic dermatitis, and the most important one was also atopic dermatitis. What about Cockayne syndrome? Cockayne syndrome, again, very important syndrome that you also come across when you read about retinitis pigmentosa. Right, so here this is a disorder with extreme sensitivity to light, and since they have extreme sensitivity to light, they're also predisposed to premature aging, and premature aging brings about cataract as well. So they will have a lot of skin problems like hyperpigmentation, spider veins, and serious sensitivity to sunlight. Now we have the Rothman-Thompson. Rothman-Thompson also is autosomal recessive. Again, a problem with the DNA replication initiation. Here again you will see skin condition. Skin condition here is referred to as the poikiloderma. Okay, so if you're interested, it actually consists of this hyperpigmented patches with some telangiectasia, that is nothing but dilated vessels on the skin. Then we have incontinentia pigmenti, which has a very characteristic skin appearance. So in the stage 1, they have this blister formation from birth to about 4 months of age. Then this blister actually becomes a wart-like lesion or a wart-like rash for several months. Then they develop this swirling pattern. Okay, and then it leads to hypopigmentation. Okay, so that is incontinentia pigmenti, right? So I hope this made your life easy. We are finally finishing the etiology of pediatric cataract. I hope these 3 videos added some value to your life. That's all for today. Thank you and have a nice day.